Hello and welcome to See What We See with Lauren and Martin. My name is Lauren Cashin. I'm the Executive Director of the Ontario Opticians Association, and I'm here with my co-host, Martin LeBeau, Deputy Executive Director of the Ontario Opticians Association.
Hello, everyone. Welcome to See What We See with Lauren and Martin. Hi, Lauren. How are you today?
I'm great, Martin. How about you?
I'm great. Thank you very much. Thank you, everybody, for joining us today. The podcast today is sponsored by the Optical Group. We are lucky to have a special guest today about something that's very interesting, something that's related to our industry as well, to opticianry. Do you guys know what an ocularist is? Lauren, what about you? Do you know what an ocularist does?
I knew you were going to throw that at me, but of course I know what an ocularist is. So an ocularist fits prosthetic eyes and scleral covers, and as opticians we know what sclerals are. And but for the average person on the street, I don't think they use the term prosthetic eyes. People would say, "Is that person wearing a
glass eye?"
Yeah,
All right.
heard that term. We've heard that term. But I, in our research, we found that it's a big profession. There's a lot of people out there that require these services, and it's interesting how we probably know people who wear a prosthetic eye, but we don't even know it.
You're absolutely right, Lauren. And I think most people that walk past you on the street, and even though they do have a prosthetic eye, you can't tell nowadays. I mean, these professionals, these ocularists, are artists.
Yeah.
I mean, they're phenomenal at what they do. And I think it's time to bring in our guest for today, because I'm excited to start talking about this. Lauren, how about you introduce our guest for today?
Thanks, Martin. So I'd like to introduce Michael Webb, who's an ocularist. And Michael, welcome to the podcast.
Thanks. I appreciate the offer, getting a chance to talk to you guys.
Martin and I are thrilled that you're here with us today. Yes.
Well, a lot of synergies, guys. A lot of synergies. It's part of the history of our company. It's part of our DNA. So as time has progressed, I mean, we've gone on different evolutionary tracks, but a lot of the same roots. And I say that because of my father, right? We've been around since the mid-40s, late 40s. My father being involved in ocularistry and opticianry, as Wade mentioned to you guys earlier. Mm-hmm. So it's
so you're multi-generational.
It is, and right now I'm in the third generation. I'm the second generation, but I've got my daughter who's taking the course right now. She's in her fourth year. Hopefully she'll be writing her finals sometime next year, what we refer to as our NEBO exams. Once she's completed those exams, then she'll be licensed and ready to go, and we will have officially our third generation ocularist on board.
Oh,
so
that's fantastic, and congratulations to your daughter. She's almost done.
Yeah. Well, I don't.
Michael, knowing that there's three generations, that means there's a history back, in the back of everything. So why don't you tell us about your history and your company and everything else a little bit?
Sure. Actually, it's funny because I was talking to Lauren about it, and it was amazing some of the connections and history that he's familiar of the people. But I'll try to give you a background on where it started. My father, just before he got into the Air Force in the Second World War, he applied for a job at Imperial Optical. And back in those days, they only made glass eyes. So he's 17, 18 years old, rare to go, wanting to get into the Air Force, but needed something in the interim. And they literally got him a job at Imperial Optical. And his job was to put together broken glass eyes, piece them together as they were shipped to them from wherever they were in Ontario or Canada. And then he would try to find the shape and color and mail them a similar shape. So that's where he started. Went off to the war. Lo and behold, during the war, glass eyes were exclusively mined, the glass from Lauscha, Germany. So ocularists around the world couldn't get raw materials.
Right.
So they came up with through the United States and England, their departments of Air Force and through the medicine, dental actually, they developed plastics, and they came up with a process for manufacturing plastic eyes to deal with all the injuries coming back from the war. So when my dad got out of the Air Force, he went back to Imperial, and they said to him, well, look it, we can give you a job, but there's a brand new realm here, which is plastics we know nothing about. Why don't you figure out how to make the plastics and go through this end of it? And they continued with their glass eye fitter and maker, who mentored my dad at the time, to learn the basics of fitting while he mastered plastics. And that's really where it started. And that's how
you mentioned about coming from Germany, because as I study our profession, opticianry, and I know that there was a lot of issues with getting glass for lenses because they were coming from Germany.
Yeah.
And that had pushed Imperial going into making the molds to make lenses in glass. They couldn't just get everything from Germany anymore. So I guess that gave everyone a kick in the butt to get moving and develop their own industries.
Well, it did, really, because I think it was referred to as cryolite glass out of Lauscha, Germany, for artificial eyes. And as I said, even the majority of ocularists in the 30s and 40s, or even the 20s, 30s, and 40s in North America were really German descent, right? In New York and in California, the Gugelmans, the Danzes, there's a lot of German families that were very, very heavily involved in this trade and field. So you can understand, Jardins, that when that became an issue of not getting access to glass, plastics had to come up. But plastics weren't really that effective at the beginning. But if you look at it today, there's not one glass eye maker in North America. Glass eyes do not exist in North America, yet they still exist in Germany and in Europe.
And why is that, Michael?
Refer to them as glass eyes too.
Yeah, and they still refer to them as glass eyes. But a good question, Martin, is that the reality of it is that with a glass eye, it's not technically impression fit, it's empirically fit. You find a shape that matches. Two, you also have to, if it's a custom-made glass eye, which truly they're incredibly skilled artisans, there's no question about it. They're very skilled. They can color it the way they see the coloring, but once you've got that, you can't change it, right? There's no adjustments to correct for edema or swelling or migration of the implant, as well as, in my mind, you're handicapped because you're not going to let a kid go and play sports with a glass eye. It's a vacuum. It's a negative pressure and a very thin-walled Snellen type of shape. So any impact on that will crack the glass and suck the tissues, the conch, into the back of it. Or you've got a socket full of broken glass. So that's why people would take them out at night. There was always a concept, you took your eye out at night. We don't recommend that at all. But for those patients that have had them from a long time, that was kind of the standard fare of what they were told to do. But the reason they were told that is, you're sleeping, your spouse rolls over and whacks you, bang, in the middle of the night, you get whacked and there you go. It's broken. So it does become an issue. So,
that's very interesting.
Yeah.
But for our listeners right now, maybe we should really dive into really what is an ocularist, because we're talking, we understand, but maybe our listeners should know a little bit more about exactly what you do, so it's maybe easier for them.
An ocularist really is a fitter and fabricator of custom ocular prosthetics. Myself, I get involved in a variety of other slight disciplines. I do a lot of work within the craniofacial world as well, particularly at a sick kids hospital. And I do a lot of pediatrics as well. But the majority of what we do are building custom artificial eyes and what I refer to as scleral lenses, which is fitting over a live eye. Okay, so there are a lot of Tysical globes. There's a lot of microphthalmic globes. There's a lot of full globes, and we endeavor to try to fit those and get a cosmetic result so they don't need an enucleation or an evisceration or surgery. So, I mean, I literally had a gentleman in here today with the same issue. He'd been hit with an injury for a golf ball, and not happy about the overall result. His eye had gone Tysical, but he was talking about eviscerating or removing the eye because what's the point of it there? I want to move on with my life. I don't want to have these issues. He'd had some complications, and I explained to him, if I'm successful, you may not need surgery. So let me have a shot at it first. Let's see what I can do. If I'm not successful, then your answer is surgery.
It's interesting because you mentioned scleral lenses and that, and you mentioned fitting over a live eye.
Yeah.
So I never even thought of that. You're involved in, like you just said, preventing him from needing surgery. So would you say most of your work is for the actual artificial eye, or do you do a lot of work with scleral overlays?
Yeah, great question. And I'm going to tell you why. When I started, I would probably say about 85% of our work was enucleations. Okay, back in 1980 when I started. Maybe even a little higher than that. Only a handful of oculists. And again, I predispose that comment to the fact that my dad had the background of opticianry and fitting contact lenses. So he had the comfort and ability to fit them. Other ocularists didn't touch lenses back in those days. Very few did, unless they had a similar background or confidence. Most ocularists, no, wouldn't touch it with a 10-foot pole, right? Today, I bet you it's probably about 50% or more of my practice is lenses. And that's because two things. One, when the eye is operated on and it becomes Tysical, there's no need to remove it if I can balance the look. There's a lot less post-operative complications, or what I refer to as anophthalmic socket syndrome complications, which is enophthalmos or ptosis or lagophthalmos, those sort of things. So it's a big difference.
So does that mean that, well, okay, let me backtrack a little bit. So I have a friend of mine that does have a prosthetic. And I remember when we were younger, he had to go for extra surgery after the fact so they can attach the muscles so you can have actually eye movement that would be similar. But I'm presuming now by doing a contact lens, you don't have to do that type of surgery. So is that what you mean by it's less intrusive, there's less trauma?
Well, again, I love your questions. I'm going to say, because you're doing my work for me. So let me touch on that. In the late 80s, mid to late 80s, a new style of implant was designed, and it was called hydroxyapatite. And hydroxyapatite is a bio-integrated implant that the muscles were attached to. Okay. Prior to that, we mostly had in Ontario silicone or PMMA spheres, and they would imbricate the muscles over the apex of that, but it didn't really impart a lot of movement. So once they were able to integrate the implant and get better movement, that became an issue. So movement was critical. And the other factor is oculoplastic surgeons became the resource for doing those surgeries. Back when I started, it was the general ophthalmologist who did them, and he might do one or two a year and one or two every 5 years. And usually the results were horrible. And even they would give it to the first-year resident with the concept of saying, well, they can't see it, but how bad can you do? Until the oculoplastic surgeons figured out that they're fixing all these problems that came from a bad enucleation. So you're correct. Keeping your eye in allows the muscles, allows less disturbance of the anatomical relationships, fat atrophy, the fat pad, all of that dissipating, and scar tissue. So that's my feeling. So if the eye gets to a stage where it's stable and not causing problems medically that they're having to manage or monitor it, then they become a good candidate for me to at least attempt to fit. And I'm not always successful. I'd love to say I am, but some of them are very difficult and very sensitive. But the majority of them done properly, we can get away with it. So movement is absolutely critical for our patients, absolutely critical.
So I don't know. I'm just thinking about the whole process, you know, how traumatic, if it's an injury, let's say. So now somebody's had their injury and they're going to require your services. So it's not something to go down to the mall and find an Ocularist store. You know, obviously there's a referral, whatever. Can
Yeah.
you walk us through maybe from beginning to end, kind of how it goes through? I have in my mind how it might happen, but how does it, because, and I've seen artificial eyes and they really match the other eye also. So maybe if you can walk us through a bit what the procedure is from you when you do your initial consultation right through to the happy patient.
So I'm going to preface that by a comment both to what I do, how I do it, and how I believe opticians can particularly be a benefit to our field.
Please.
And I'm going to start that by saying, you're right. If it comes from an injury, it comes from disease, it comes from treatment, it could come from cancer. It comes from congenital anomalies as well. Birth defects are a very common situation for us, and I deal a lot in sick kids with pediatrics for birth defects, congenital anophthalmia, congenital microphthalmia, those sort of things. So they tend to come directly from oculoplastic referrals now, because again, oculoplastic surgeons tend to be the ones doing the enucleations. Very, very rare, unless it's a severe trauma case that they had to jump in right away to do an enucleation for an emergency, would it be a non-specialist to do it. So they come from the ophthalmologist, they come to our office, they'll spend 2 days more or less in our office, a series of appointments. The fitting, I'll take a gel, an alginate type of impression inside the socket to get a concept of the fit, or over the live globe. I'll cast my lens, design it, built on that. I paint the iris as the patient's sitting in front of me, okay? So every detail, every chromatophore, every arcus senolis, every, cryptofuchs, every little aspects, primary, secondary, collarettes, all of these are based on the structural foundation of that iris. I try to mimic in my iris. So then when it's built, I then process it, they come back, and then I put the vascularization on. And when the vascularization is on, I then finish that, so all the veins are matched, the scleral tones are matched, the fit is matched, and I complete the eye. But what I wanted to talk to you about the connection between opticianry is there's one aspect that a lot of people don't understand when you talk referrals. You're talking referrals of people that have had this incident happen to them in this country. You must understand the level of immigration that we have in this country. You would be shocked how many of those individuals have acquired this injury in their own home country, right? Whether it's a war zone, whether it's a poor surgery, whether it's disease. So when they come here, many of them don't understand the options available to them because they weren't available to them there. They might have had a traveling medical officer give them, or an optician or somebody, an optometrist or a surgeon, give them an artificial eye. They'll pull out a stock one and put it in them, and they have no idea. And they were never told that, that this isn't permanent. So when they come here, they'll end up usually getting their glasses looked at. And if the optometrist or the optician doesn't ask the right questions, you've done a huge disservice to that individual, because they won't ask you. They're usually embarrassed by the look of it. They don't want to talk about it, but they will talk with a professional if the professional asks the right questions. When was the last time you had it cleaned? How old is the eye? Where was it done? And if you leave these eyes in, particularly stock ones, you end up with irreparable damage to the lids and the surrounding adnexia, where you get contractive tissues, where you eventually end up having to have complete facial reconstruction to rebuild that socket just to be able to maintain or retain a prosthesis. So by not asking those questions, you put them at risk. So to me, the person that can ask those questions is that healthcare professional, which is an optician. When they come to you, you have the door open to ask that. You can't come up to them on the street. I wouldn't come up to them on the street and say, hey, by the way, when's the last time you had that looked at? It looks horrible. Not in a million years, okay? I can be with people and they said, that guy had an artificial eye. Why don't you say anything? I said, because it's not my place. Right? I see them on the street. It's not my place. It's rude and ignorant to me. Had they come to see their healthcare professional, the referral can come appropriately. But unless that healthcare professional understands what they're seeing and what they're asking, again, I regress, it's you do them a disservice if you don't ask them about their other eye. They may have no vision. You might put a plano lens, but that's how it works.
That's great, Michael. That's probably going to help a lot of opticians actually that probably went through this, but they didn't know what to do about it.
Yeah.
But at the same time, this type of service, is that something that's covered by OIP? Is it personal insurance? Is it out of pocket? How does that work that way?
Well, we're fortunate to be living in a province of Ontario. And I'm going to tell you that is because the assistive devices program in the province of Ontario was the absolute leading edge in this field in the world. And the reason being is that when they developed the assistive devices program, which covers 75% of the cost of my services to every patient I see, the balance, or 25%, is paid by the person's insurance company or services like ODSP or NIHB or whatever the case may be. WSIB is completely separate. ADP recognized the level of requirement for education, and they built that program around that to enable people in the province of Ontario to receive that quality of care, because they recognized without that level, they do a disservice to the people in this province, because you get poor health care, you get people who are untrained, you get people who don't know what they're doing, and they basically wiped that out. And it became the model of standardization of certification across North America and in many cases the world. And again, I put that down to the Ontario government having the foresight to understand that this needs to be a regulated industry, because in my dad's day and age, it was not. And it is not in the US. It is not in the US. Many of the states have unlicensed individuals doing the work.
I mean, that's great, because a lot of time, we don't always have to say positive things about the government, right? But this is a great example that, the government helps us. Like you said, we're lucky to be in Ontario. ADP does great things. They do great thing with what you do. They do great thing with low vision and other things as well. So, that's great that you pointed that out. Thank you, Michael.
Let's face the fact, they're there for a reason. And that reason is to protect the people in this province and provide the best level of care and service. And every now and then they step up to the bat and do that. And ADP just recently did that in negotiations with our field. It took us about a year. They drilled us down on every aspect. They wanted to realize where we were, but they wanted to bring the program back up to a functional level where it was a reasonable field that could sustain itself. But they actually took the time to do it properly. Drove me nuts. I mean, I'm the president of the Canadian Society of Ocularists, and I can tell you, I jumped through more hoops. But you know what? When they do it for the right reasons, you got to give them the respect they deserve. And I did. And I always will for that reason.
That's fantastic.
So here we are. We've just paid for it. So we know, which is wonderful that it's basically covered 100%. Now I'm thinking of somebody now, they've gone through the process with you. How... I think of different things. Is a prosthetic comfortable? Do you run into dry eye issues just like people do who have both their eyes? What's the maintenance? All these questions are coming to my mind. I've been fitted. I walk out the door. Now what? How do I maintain this device?
Yeah, I kind of look at very similar to, in some ways, dental. You get your teeth cleaned a couple times a year because of the plaque that builds up on your teeth. You know how protein builds up on a contact lens.
Yes.
Okay. Well, multiply that by 10 on a prosthetic. Oh. So protein is attached to the surface of the PMMA, and we need to get it off. And we do it about twice a year. The Ontario ADP program allows that to happen. They cover it twice a year. I have some people do it once a year. I have some patients need to do it 3-4 times a year. Everybody is different. So maintenance and care and control is incredibly important. And again, kudos to the government for recognizing and covering that, because it enables a better level of healthcare if people look after it. It prolongs the use and prolongs the health of that socket. So when people run into problems with eyes, it can come from a variety of areas. It can come from the initial fit. It can come from the initial degree of comfort, how things were done. It can come from edema. It can come from other issues where the implant itself is starting to migrate, or there's pyogenic granuloma developing within the socket, or they've got a chalazion or a sty that's complicating. And dryness, as I mentioned to you earlier, Lauren, they have so many options for lubrications for individuals on the market today for people who have two eyes. A dry eye is a prosthetic because you're blinking over plastic. There's no question tear supplements are absolutely critical to us in the maintenance and management of these patients. I don't like to use it for children, and I don't suggest that. I like to learn my way along. I like to find when that patient needs maintenance and when they can benefit from the use of lubricants. So I'm very much somebody who tries to stay away from them until I see the need. And then not any lubricant is the end all to be all, right? Sometimes a gel, sometimes an ointment, sometimes a drop, right? Everybody is different. So we try to find that balance with them.
Is there, are these, because you mentioned with the glass eyes that they had to remove them because of the safety factor. Does the average patient leave this prosthetic in the socket until they come see you in 6 months? And my second part of the question, is I got so many things I'm thinking about. Is there a cleaner, or is it just the, do we clean the prosthetic while it's in the eye, and does the eye come out at night at any time?
All right. I'll try to answer that as quickly as possible because there's a lot of variations in that question. So first off, you mentioned the socket. Do they leave it in the socket? Yes. When you talk about a socket is something that you've had the eye removed. When you have a lens, I start those lenses off, which is a fitting over a live eye, particularly if there's a cornea there. If it's an evisceration with a keratectomy and the removal of the cornea, that it's not an issue. But if there's corneal tissue there, my design, my configuration, my guidance to my patient is to remove it at night and let the cornea breathe. But I can be honest with you, I'd probably say about 75 to 80% of my patients wear them full-time, months on end, and never remove them as a lens. As an enucleation, I do not like them removed. And the reason I don't like them removed is that there's a very low percentage of individuals who will contract that socket if you leave the eye out. So when you leave it out at night, they'll wake up in the morning, they can't get the eye back in.
Oh.
Okay? And the socket can collapse. And usually it's relative to thermal chemical burns, radiation therapy, a variety of scar tissue from multiple surgeries. But I've had those with no history of any of the above just spontaneously contract on me for no reason whatsoever. They got an infection. Their doctor says, leave the eye out. All of a sudden, bang, can't get the eye back in. And now it's reconstructive surgery. And that's either taking dermis fat graft or oral mucous membrane from the lips, or buccal mucous membrane from the lips, or oral mucous membrane from the cheek, to try to line the socket, reconfigure it, and surgically I design a piece that goes inside there to stabilize the socket, and we run tarsorrhaphy sutures through them. And I work in the operating room of the oculoplastic surgeon to try to rehabilitate that. So yeah, I don't take the chance. So it's a defined question.
There are so many interesting aspects to this. I mean, we could be talking about this. I believe like our podcast could be like 3-4 hours long, and we still have more to talk about.
Yeah, I apologize, guys. Sorry.
No, don't. I mean, it's great information, and I think our listeners are going to want to know more and more and more. So maybe we can do a second part of this down the road. But right now, I mean, my curiosity is peaked to its max. How can I become an ocularist? What's the process? What's the schooling like?
It's right now, the College of Ocularistry is in the United States. It's a 5-year program. You apply to the college. It's a co-op program. You need to be working under the certification of a board certified ocularist or an EBO certified ocularist as your proctor. And then once you've passed your levels, your 4th year, you eventually are able to write in your 5th year what we refer to your national examining certification exams, which is a multi-pronged exam that goes on for a couple days. Fitting, fabrication, test shapes, and it takes probably several months for them to finalize the data, and then you can determine if you've been successful in your endeavor and become certified. But it takes about minimum of about 5 years under that process, through the college and through the American Society of Ocularists.
Are there prerequisite to this? Do I need a bachelor in science? Do I, being an optician, do I get to have like half the courses done already?
Well, my daughter has did hers in business, because she did a 2-year program originally, because she said, Dad, do I do a 4-year? And I said, you do 4 years and you have 5 years of mine, 9 years, 7 years, you can be a doctor. What's the point, right? We argued that with our association. Many of them, truly, many of them come from different disciplines. Many of them have bachelors, PhDs. We've got just about every gamut. I mean, when I've taken students, I've trained about 13 students. I've had everything from surgeons, doctors, pediatricians, electrical engineers, you name it. The ones that I found the most functional actually were college students. And the reason being, with a college background, it shows the discipline of learning, but there's always that drive to learn more, and not the assumption that they know what they're doing. They're willing to learn. And so those have been the more successful candidates to me that have gone on to succeed in this field. Mm-hmm. So we argued with our association about, they wanted a bachelor's degree. And I explained to them, a bachelor's degree in this situation kneecaps us, because there's just not enough of us out there to get the knowledge to have somebody go through and spend 4 years to get your bachelor's, and then come into this program as an apprentice and spend another 5 years, right?
Mm-hmm. And at the end of the day, you're regulated by the College of Ocularists of Ontario?
Yes. No, there is no College of Ocularistry in Ontario. It's in the United States. The college is in the US.
So it's a non-controlled act then in Ontario?
Well, no, you have to be NEBO certified in Ontario. So the requirement is to have your NEBO certification to practice in this province, which is part of the ADP requirements as well.
I see, but it wouldn't be listed as one of the controlled acts in Ontario.
Well, we're too small.
I see. There's
a handful of us, in Ontario, you've got to understand that there's only a handful of ocularistry based on a population. Usually about 1.5 million people will be a functional call for an ocularist based on patient base. So, you can understand that the dynamics, there's not a lot of us around North America in particular. I think there's about 20 some odd of us across the country that are licensed ocularists today, right? And there's a few that are what are referred to as fellows, which have gone to that extra level and achieved what we refer to as a fellowship. So there's a handful of us that have fellows.
One last thing, Michael, before we let you go. If people want more information about your profession, about what you do, is there a website they can visit? Your own website or your association website?
I'm biased. I like my own website, but then again, I have nothing to do with it. My daughter and that do. And they're far more tech savvy than I am. So yes, there's a lot of information on our site to give you what you need to learn and know. There is information through the American Society of Ocularists. You can go in there and see, and particularly if you're looking for an ocularist, say for instance, you're from out of the province, or you're from, in the western part of Ontario, and you want to have an ocularist that's closer to you, you can go on the Canadian Society of Ocularists and see the range of ocularists that are available to you, depending on where you are, right? So you must understand that there's mechanisms in both ends. The Canadian Society doesn't give you the information per se, but the American Society may give you more connection to information, and my site would give you information necessary for you if you were requiring the services.
And Michael, sorry, what is your website again?
Webocular.com.
Listen, Michael, thank you so much for joining us today. This was an eye-opener, pun intended.
I've heard that one before.
But definitely, let's catch up again sometime soon, and hopefully we can learn a little bit more about your world. And again, thank you so much for all the information
Listen,
today.
guys, it was a pleasure and a treat. So thank you for giving me an opportunity to chat with you. Obviously something I'm passionate about, obviously something I love, but I love it more when people want to know more about it, and particularly in a sense from you guys, where there's a benefit of being able to pass that knowledge off to those that are your listeners who could benefit and maybe help people out. So love it. So thank you, guys.
And thank you, Michael. I appreciate it.
All the best.
Well, Martin, that was certainly an interesting discussion.
Absolutely, it was. It's lots of great information.
Yeah, I could have spoken to Michael for a lot longer, because every time he went into something, more questions were popping into my mind that I'd love to speak to him. So as you mentioned, maybe we can get him back again and have a part 2.
That would be great.
Mm-hmm.
Even if it were just us going for a coffee with him, I think I could absorb all the information that he was giving very, very easily. It was such an easy, it was an easy conversation to have with him, really, at the end of the day.
Yeah, well, he's a true professional, and he's very passionate. And I love that it's a 3-generational family business. It's wonderful.
Yeah.
So I guess that wraps it up for today. Martin, why don't you take us home now?
Thanks, Lauren. Today's episode was sponsored by the Optical Group. Catch us up on our next episode of See What We See with Lauren and Martin. Thanks, everybody. Talk to you soon.
Thank you for listening to See What We See with Lauren and Martin. Be sure to follow us across our social media pages so you never miss an update or an episode. You can find us on Twitter at OOA_frontline. On Facebook and LinkedIn, we are Ontario Opticians Association. Follow us on Instagram at Ontario Opticians Association. That's all one word. We look forward to seeing you again on See What We See with Lauren and Martin. Take care and stay safe.